Good afternoon, everybody. Hi, this is Mike Lewis, and we are going to be going over today the 2025 PFS final rule, understanding their importance on MIPS as well as ACO reporting moving forward into next year. Today I'm going to be joined by Lauren Patrick, our CEO and President. Lauren, say hi to everybody.
Good afternoon, everybody. I hope you're having a great day. It's 75 degrees here in Philadelphia, Pennsylvania on November 8th.
7th. November 7th. All right. First off, some housekeeping, handouts, and questions. There's an ability to ask questions on the app if you look up in the top right-hand corner. Please feel free to ask questions. This is a very full webinar, and we're probably going to go right up to the hour, so answering them live might not happen. We'll try our best. However, Lauren and I will get back to you within the next couple of days with your answers. Also, on top of that, I'm going to share that you'll get the handouts for everything here. There's a link right here for them, as well as I'll send them to you afterward, along with a copy of the recording. So you'll have everything you need if you can't stay the whole time, or if you want to share it with your teammates, you'll be able to do that. I will ask at the end of the webinar, when you hit the button to leave, there is a survey. Filling out your survey is the best way for us to improve on what we're doing and how we do it. So please fill out that survey as we move along. So the things we're going to review today, changes to traditional MIPS, the enhancements to MVPs, as well as what's new with the APP. Lots of initials here, but we'll spell them out as we move along in the screens. So what is CMS's plan QPP for the QPP policy and updates? The real thing is that they built these pillars now. Now they've had them for a long time, but they're really making them stand out when you take a look at the direction that they're moving. So between alignment, growth, and equity, their plan is to utilize all of these pillars to build the future of this program. So focusing on the future of MIPS by growing MIPS value pathways, we're going to spend a lot of time taking a look at what that growth in MIPS is, as well as the growth in MVPs. As a lot of you know, there are some new MVPs this year, and the participation that they're the ability to participate in MVPs is over 80% of providers. Updating MIPS scoring policies to provide a more equal playing field for all practitioners. You'll see some changes this year. I don't think they've gone far enough, but they will in the future. And then there is a new introduction to the alternative payment model. It's now the APP Plus quality measure set that you will see. I've seen a couple hands raised. I won't be answering live questions, but if you want to leave questions for me, I will have the ability to answer them at some point today or later. So let's start off with some of the basics. I'm going to go quickly through these. Everybody's very familiar with these if you're familiar with MIPS. If you're not familiar with MIPS, I do have some presentations that I've done on back to the basics and basics and so forth. So you will have the ability to catch up and then rewatch this to understand some more. But for MIPS 2025, it is the same as 2024 when it comes to the category weightings, with quality and cost being equal at 30%, as well as IA staying at 15 and PI at 25. There are a lot of different ways that this can be redistributed based upon your practice size, specialty, the types of patients you see, area that you live in, things like that. So the eligibility is staying exactly the same as in the last, I think, 5, 6, maybe 6 years. So the minimum to avoid the penalty for MIPS in 2025, they're keeping it right there for the fourth straight year at 75 points. I do believe that they're going to keep it at 75 for a bit of time as they're changing a lot in the program and they're changing how they want people to do things. I think they're trying to keep it even at 75, so that at least that's one thing that is flat. So as you can see, it's grown since the beginning of this stages back in 2017. All right, let's jump right into MIPS quality. When there are things here that we'll go over MIPS, and then after that we'll go through MVPs and then the ACO stuff. I hear some people may be having issues with connection and being able to hear. We've started the webinar. If you're not able to hear me, then this does you no good. We'll answer those questions to those people as we go along. So the first part is 75% data completeness. Criteria thresholds for all reporting pathways will continue to be at 75%. CMS has been pushing and pushing and pushing to increase this benchmark in the future, but they're maintaining that 75% at least through the 2028 program year. The quality measures that are available, here are, there has not been a ton of changes. It ends up being, they added 7 new measures, they took 10 away. So it really is just dropping 3 measures in the overall number. The big thing is there are a lot of, some of these removed measures are popular measures that you've been working with. So I do want to kind of explain to everybody what the measure removal criteria is. I think it's interesting that year after year we take a look at this measured population and inventory that they have, and you can see it's slowly dipped, but we've been below 200 for 3 years now. There are a lot of problems with that, and that is that they're not really creating as many measures as they're eliminating, and it's causing some of the population not to have measures that really can work for what they do. So the quality measure inventory has had a minimal fluctuation, and this is causing problems with those practitioners. So why does CMS remove measures? There are a number of reasons. I tried to categorize them into these six points. They're no longer meaningful. The measure steward can't maintain them, so the measure steward may not be CMS for a lot of these measures. It might be a specialty society or a different group that creates it. A measure's reached extremely topped out status. We've gone over the basics of that before, but to be an extremely topped out status means that you can't score better than it. Then averages are in the high, 99% and above for those measures. And when that happens, they can eliminate that measure right away. Otherwise, not enough people report on a measure for 2 straight years. A measure is duplicative. That happened last year with measures 154 and 155. They combined them together and removed one of them. And a measure isn't updated to meet current clinical guidelines. This has happened a few times. It's happened with measures where they didn't necessarily get rid of it, but for instance, like measure 1 for diabetes, it was updated to meet the current clinical guidelines with their scoring over the years. So they were able to keep it, but otherwise measures like that would disappear. So new quality measures for 2025. You can see here we're in the 500s, everybody. It feels like a long time ago that we were in the low 100s with these measures, but the first one up at the top was a measure that was released last year. However, it is only going to be available in 2025. Then they have the new measures that were approved. There were more that were proposed, but 2 of them were taken out, the patient reported outcome measures. were taken out due to the steward not being able to maintain them moving forward. And then if you see the last one on the bottom, measure number 9, they've now added an ECQM option for this year. So there is another option for reporting those measures. Quality measures to be removed. I'm not going to go through each one of these, but there are some popular ones, especially with our client base, like 137, melanoma continuity of care recall system. They've created that new measure that you saw on the previous page. So this one's going to be removed moving forward. This was highly topped out for a very long time, but they kept it in there. There are measures for oncology they're removing. Some of the reasons that they're removing them are they reached the end of their top out life cycle, like I pointed out earlier. Duplicative measures. Duplicative. Holy cow. I'll get it one of these days. Duplicative measures for 451 and 452 were the same. So they got rid of 451. But you could see by looking at the numbers when they come out for the benchmarking for these measures that they say will be out in January. You can see that these were on those lists as highly topped out or not being reported on and so forth. So there's guidelines year after year for what's going to be removed.
So Mike, for that measure 137 that was removed and replaced by a new measure, all those new measures on the prior screen are going to get 7-point minimums for 2025, right? So that's actually a win for those that used to use 137 if they can use the new measure.
Correct. Yeah. The 7-point max, thanks for reminding me, there is a floor for these measures. So the minimum
for the new measures.
So a minimum points you're going to get is 7. And as a lot of you have talked to me over the years, well, I'm reporting a bunch of measures where the maximum is 7 points. Well, this is a minimum of 7 points. There is not a current benchmark for these measures. However, you could score from 7 to 10, but you will never get them less than 7 points for these measures that are here.
So the way it's going to work is for these measures, you're going to get a minimum of 7 points for reporting them in 25. If they have at least 20 practices or individuals that report them, and they report at least 20 eligible instances each, then CMS will assign benchmarks for 2025 retrospectively at the end of the year. And you'll be able to get anywhere from 7 points up to 10 points. So these are great measures. If you don't have measures where you're scoring super well, these are great measures to see if you can incorporate for 2025. And then what happens is in 2026, you'll get a minimum of 5 points for each one of these measures. And they'll do that same sort of analysis where you can get anywhere from 5 to 10 points on those.
Thank you. And someone just actually asked a great question here. Do you need to have 20 instances of the measure? You don't. You need to have 75% completion threshold. You need to meet that. However, you could be 1/7 or 15/15, and still the minimum amount of points that you will get is 7. All right. On to the substantive changes for 2025. There are some big ones. There were many more. I think 66 was the total number of changes. I'm not going to go once again all through all of these, but the breast cancer screening and colorectal screening measures that are only available in MVPs currently, and then in 2025 they'll be available. At least the breast cancer screening will be available for MSSP ACOs. They've now added any patient 66 and older who has a diagnosis of advanced illness as an exclusion. So giving more exclusions and more opportunities for each one of these measures to be more accurate to what they want to get. There was one on here I wanted to point out. The kidney health evaluation is changing the years, adding 10 years, but the last two that you see down the bottom, the adult immunization as well. Here, a very familiar part of this measure is the pneumonia vaccine. This is moving from the minimum age of 60 to the minimum age of 19. So that is a really big drop for that, and that's asking clinicians to take a look at pneumonia all the way down to the age of 19, not just worrying about those that are 60 and over.
So yeah, your denominator is really going to increase.
Yes. Specialty measure sets, why are they increasingly important? Because there's limited measure choices for specialists where the measure development has been below the expectations. CMS said some things like, make sure you talk to your specialty society so they create more measures that are meaningful for you. Work on measures that are outcome based instead of process based to help build measures that we'll accept. So what is changing for 2025 is that they're going to eliminate the 7-point topped-out measure score for clinicians reporting certain specialty measures. So the specialty measures that they're doing that for are going to be pathology, anesthesiology, diagnostic radiology, and radiation oncology. What I'll find interesting for those two as well is that those are ones that have a hard time coming up with cost measures because these are patients. Most of this is patient. They're not seeing patients in front of them, especially pathology and diagnostic radiology. The new specialty measure set is optometry. They were going to put it together with ophthalmology, but decided to make their own specialty measure set. CMS is planning to develop MVPs addressing multi-specialty measure sets. Basically, the idea would be for a group of similar specialists that can work together, like a dermatologist, a plastic surgeon, and a Mohs surgeon, all looking at the same patients within an MVP, while they all may have different eligibility for each of for the way they work. So that should be interesting as they're planning to do things like that. So when I talk about the limited topped-out measures, so CMS is applying a new benchmarking approach for these measures used by the specialists that were in those limited specialty sets that we were talking about. These measures will no longer be capped out at 7 points. So this is throwing some very important measures that a lot of specialists are looking at back into play as a maximum scoring. And as you can see on the left-hand side, this is what we call flat benchmarks, but scaled. So you can see if you get 84 to 85, you're looking at 1 to 2 points, and then they do give you the ability, if you're up in the high 90s, to be able to get 7, 8, and 9 points for these measures. So I did want to update, not all of this is new information not all of these is new information, but I did want to reiterate some of it on here. So the minimum criteria, this is new. Submission must include a numerator and a denominator information for at least one measure. Submissions that don't have any scoreable data wouldn't satisfy the submission. And the policy is intended to mitigate the negative impact due to unintentional submissions. There is a new APP plus quality measure set that we're going to go over in future slides. This is now an option for MIPS eligible clinicians, groups, and APM entities. But to meet the reporting requirements, you have to report on all the measures in the measure set. Now this is a little tricky down the bottom, but multiple submissions is something that we deal with here a lot at HealthMonix, as people are submitting early, which we recommend, and then resubmitting later. But here's 3 scenarios that I did want to lay out. So when multiple submissions are received using different methods, let's say you are reporting through MIPS Pro and you're also reporting some measures through your ECQM for the same reporting option. So whether it's traditional MIPS or MVPs, CMS is going to take the highest score for each measure. So you can score an ECQM measure number 1 and a CQM measure number 47, and they will, if they're your highest top 6, they'll both count. When multiple submissions are received using the same method, so let's say just all registry reporting for the same reporting option, just for traditional MIPS, CMS is going to take the most recent submission. So if you're here with MIPS Pro and you are reporting in February and then you realize that there is more data or changes that you need to make and you re-report, you don't have to delete your submission. It would just be replaced for you. And then when there's multiple submissions are received via different methods, so once again, your registered MIPS Pro and your EHR for different reporting options, so let's say MVPs and traditional MIPS, CMS is going to provide the higher of the two scores. We've talked about that a bunch. There's a bunch of different ways to look at that. But basically what this is saying is that you can report MVPs and traditional MIPS in any method. CMS is going to take the highest of those two scores at the end and provide you with that score only. All right, on to improvement activities. So this is the biggest change in improvement activities, I think, in, I don't know, 6 years, 7 years. They've decided to remove the activity weighting to simplify scoring. So what that's going to do is instead of you having the high and medium weighted, they didn't make it low, it was high and medium. They're all going to have the same high weighting. So if you are doing traditional MIPS and you're a large practice, you still need to do 2 activities. Traditional MIPS and you're a small practice, 1. Traditional MIPS and you fit any of these practice types, whether it's rural provider shortage area or non-patient facing, it's 1. And then anybody that's doing an MVP, also has 1/2 as much as the traditional practice. They're only adding 2 measures, they're removing 4 and modifying 1. The minimum submission criteria, so you must include a yes response for at least 1 measure, basically saying that you can't submit zeros. And if multiple submission criteria, CMS will take the highest score if a submission type is different. So just wanted to add these in as people ask those questions often. Not going to go through this, but they added 2 new activities. They modified 1 activity. Basically, this one here is they took the COVID vaccine and bumped it into a, this shouldn't say proposed anymore, this is good, but vaccine achievement for practice staff, COVID-19 for flu and hepatitis is now all combined into 1 measure. All right, I get to hold my breath a little bit now and go back and hand this over to Lauren.
So the cost category does have some significant changes, both for 2024 and for 2025. So listen up. First of all, for 2025, what CMS has done is they've added 6 new cost measures, and most of them are chronic measures, and then there's 1 acute. And then what they've also done is they've made significant changes to the cataract removal measure and to the PCI measure. So if you're involved in those sorts of activities, we can help you understand what the changes are with them. I'm not going to go into all of them here, but there are going to be more measures. What CMS is really trying to do is to cover everybody with cost measures. So if you haven't had cost measures before, you might want to check and see what's going to happen in 25 and see if any of these measures are going to apply to you. Don't just assume from the names, if you're not a kidney doc, that, you're not going to be hit by some of these, because for example, CKD is really being attributed to a lot of different provider types as we move forward. So just make sure that you check those. We may do a webinar on what these measures are and how they impact people, because I think we're starting to see a lot more impact. Like I said, the cost measures are really being developed so that all providers within MIPS are seeing some measures attributed to them.
And Lauren's catching my mistakes. I missed proposed cost measures. Those are cost measures. They are in the final rule. All of the proposed ones were accepted for 2025.
So in terms of changes to cost scoring, this is big. So CMS is modifying the methodology for scoring. So I don't know how many of you received cost scores for 2020, for last year and the year before, but what CMS was seeing was the average cost score was 59%, and the average quality score tends to be around 74%. And then for PI and IA, they're much higher. They're like 95 and 98%. So folks were seeing a significant loss of points in the cost category because what CMS was doing was they were holding everybody to a median score. So if you came in on average, you were going to get a 5 out of 10. So they're saying that on average, people were getting like 59 out of 100 points, or what is that for 30? I can't do that division. 20 out of 30 points. And folks were complaining about that. So they're changing it up, and not only are they changing it up for 2025, but they're going to apply it to the data that's being used for 2024. So what they're doing is they're looking at the average score as they've done in the past, and they said rather than giving a provider, if they're at the average score, rather than giving them 5 points, they're going to give them 7.5 points. So that's a big win. And then what they're going to do is, rather than what they used to do, is they would take every 10% of providers, and that's how they would divvy up the scores. And when the scores would group, it would cause people that were just a little bit off to get an even lower score than 5. So what they're going to do is two things. They're going to bump up the median score to 7.5, and then they're going to change it to this standard deviation processing. And like it says here, CMS anticipates that on average, providers will see an extra 3.9 points, and it won't punish providers. I think on the next screen we have an example. So on this screen, what we're showing is in the current policy, which was for 2022 and 2023, you would see that it was just based on percentile, kind of like what we do for quality. And they found that everybody was bunching together. So now what they're saying is that if you're at the median, you're gonna see that you're at 7.5. And then they're gonna look at standard deviations. For those of you that were math or statistics majors, you're gonna love these algorithms. And they're gonna adjust your score based on where you fall against standard deviations. Again, just to throw in a plug, we have a cost product, and if you want help figuring all this out, we can help you figure it out. Mike, if you go to the next screen, it might make a little more sense to folks, because here we're actually showing an example. So in this particular case, we're looking at, I think this is colorectal screening. The average for 2023 was $969. And Dr. Clark was at $1,100. And you can see that because things bunched up so much, and because the average points were 5, because Dr. Clark's average was, what's that, $75, no, not 75, $35 higher on average, which is not a lot, which is what, less than 3%, she was getting dinged. So what they've done is they've moved the average up to 7.5, and then they've elongated the standard deviations so that Dr. Clark, under this new scoring, would receive between 6 and 7 points. So they think this is fair to folks because of the spread, and also you'll see a bump in overall scores. If you want to talk through any of this, then ping us, and we're happy to go through it in detail for the measures that are applicable to you.
Back to me so soon. All right. So promoting interoperability. Well, as if you remember from the proposed rule, there's not a lot of changes this year. A couple things I wanted to point out. Clinical social workers are no longer automatically reweighted. They were kind of like the last standing specialty that isn't that hasn't needed to report promoting interoperability, but in 2025 they need to. The only clinicians and groups that will continue being automatically reweighted are going to be your ambulatory surgical centers, your hospital-based providers, non-patient facing, as well as those that are considered small practice, which is 15 or fewer physicians. If you go on to the QPP site and look up your MPI, you'll be able to see all of those specialists combinations, as well as in our system. If you are connected to CMS, you'll be able to see whether you're small practice and so forth. The multiple submission rule. So starting in 2025, CMS will calculate a score for each submission and assign the highest of the scores. Laid this out here. There's absolutely no change from 2024 to 2025, but I want to make sure that it's available to everybody here. Let's go into MVPs. So for MVPs, a couple of updates from them. More than 750 groups, I say more, but that's really not a lot of people, registered for MVPs in 2023. CMS understands that when they look at these MVPs, the measure options, at least in 24, were poor. A lot of topped-out measures, a lot of measures you couldn't get to 20 patient minimums, things without benchmarks. So it made it very hard for people to do MVPs in 23 and 24. I look forward as we see some of the new measures added for 2025 into these MVPs. I look forward to having the ability to see what their benchmarks are, to see if it's a better opportunity moving forward for MVPs. The concept is great, but the execution right now is not where it needs to be. The two neurology-focused MVPs are being combined into a single neurological MVP. CMS has added 6 MVPs. Now, what I said earlier, 80% of specialties are able to participate in MVP. The scoring population health measures was updated. So no longer do you need to pick a population health measure at the time of your registration. Now what you'll have is they'll provide the highest score of all the available population health measures that are in the MVP. Subgroups are required to report their affiliated group data for promoting interoperability. It's been the same rule, but I did want to share that as that has come up in questions throughout the year. So finalized changes to existing MVPs. There's a lot of information here. The couple things I wanted to point out is that the IAPM 26 is actually just a change in name of one of the measures, and now it's new. There are a number of cost changes, as you can see on the right-hand side, added cost measures to some of these existing MVPs, and not terribly a lot of movement in the quality measures. So this is the first page, and then here is the second page where you see there's absolutely no cost changes, but you'll see some changes on both IA and quality. You'll have this in the document that will be filed that you could download on the site. Some of the finalized new MVPs. We have one for complete ophthalmologic MVP. You're going to see 18 MIPS measures, including 6 QCDR measures, as well as 14 improvement activities and a cost measure. One that's special to me because I worked a lot in dermatology and GI. They now have derm and GI care MVPs, giving those groups the ability to report and participate in this new program. Optimal care for patients with urologic conditions, as well as pulmonology MVP and a surgical care MVP. We have a big contingent of surgical care providers here, including anesthesiologists and those that are in surgery. So that's going to be a big one for us here at HealthMonix. However, we can support all the MVPs that are available, and we can help you maximize your scores when delivering those submissions to CMS. All right. Now we are shifting from MIPS, so MVPs, traditional MIPS. Now we're moving on to the Medicare Shared Savings Program. This is the MSSP, and these are the 400 to 500 current ACOs that are in this program. So what are some of the updates? This is finally the last year of CMS web interface. I think the original final year was 2020. They've pushed it back, but now this is the last one here. CMS has also introduced a new quality measure set called the APP Plus. And it's an additional quality measure set under the APP program. Very confusing, but if you have questions about it, we can walk through it. In 2023, 39% of ACOs earned health equity adjustment bonus points. I am passionate about the health equity, so I always like to mention, the opportunities you have of incorporating health equity into your organizations. CMS did not sunset MIPS CQM reporting. That wasn't the proposed rule, and vigorously commented on, and they decided to keep it at least through 2026. And then they also are finalizing a complex organization adjustment starting next year. So we're going to go through each one of these as we move along. So introducing you to the APM Performance Pathway APP Plus measure set. So the APP Plus measure set is a second distinct measure set under the APP. We're still going to have the opportunity for the existing APP quality set, but the only people that can report them are MIPS APM participants. All right. So the option for us it is an option for all MIPS eligible clinicians, groups, and APM entities. However, it is mandatory for MSSP ACOs. It includes 5 current APP quality measures plus breast cancer screening measure that's being brought back, or as part of MVPs, but is being brought back into ACO reporting. 5 additional measures are going to be incrementally added over the next 3 years. But the most important thing, and I think very interesting that we're getting there, feels like we're much closer than we've ever been before, is that they're utilizing the Adult Universal Foundation quality measure sets for both adolescents as well as adults. And what their plan of attack here is really to combine a lot of those measures that they're tracking in your quality reporting here to also be part of traditional MIPS and MVPs, the Medicaid core sets, the star rating system, as well as the Advantage Part D star rating system. So they're trying to get all of these measures, these ECQMs, to be the same. On the left-hand side, just a chart of the number of ACOs that started reporting, and that will increase in 24, and then it's got to be 100% in 2025. All right, this is a full screen, but they made a lot of changes as they were coming out with this APP Plus quality measure set. Even from the proposed rule, you could see in 2025, we have 6 measures. So we have diabetes and depression and controlling high blood pressure. Those have kind of been the key ECQMs. We have the CAPS for MIPS survey, as well as the hospital-wide 30-day readmissions, 479. And then adding new this year, the breast cancer screening. They actually bopped 484 down a year because that's the only measure on this list that is not part of the Adult Universal Foundation measure. So that's why it was part of it in 24. It's now not part of the APP Plus measure set in 25. In 2026, they're going to add colorectal cancer screening, as well as clinician and clinician group standardized admission rates with multiple chronic conditions. Those are being added for 2026. In 2027, their plan is to add 305, which is the substance use disorder treatment. And then in 2028, the plan right now is to have screening for social drivers of health as well as adult immunization status. What we're waiting on for those last 2 is that they need to create the ECQM for those measures before it's applicable for this program. So they say at the earliest, it's going to be 2028. However, the first time that they can actually add it to the quality set is 1 year after the ECQM becomes available. So updates to the Medicare CQM. So you are able to report MIPS, traditional MIPS providers can report ECQMs or CQMs. As we move into these ACOs, these MSSP ACOs, they have a third option called Medicare CQMs. So there's been a couple of changes in the Medicare CQMs for the 2025 year. What you can see on the left-hand side is that the quality measures with flat benchmarks. I don't have a picture of what a flat benchmark looks like, but it's very similar to what you saw on the cost model, on the cost slides, where every 10 points you get a point. So if you score an 85, you'll get 9 points. If you score a 75, you get 8 points, and so forth for these measures. It allows you to understand what you need to score in the beginning of the year to get to that 40th percentile. Medicare CQMs are going to use the flat benchmarking for the first 2 performance periods, and they aren't retroactively. So this isn't for 2024, this is for 2025 only. And that's only because historical data for these Medicare CQMs is not going to be available. So as you can see, each year they're adding 2 on. CMS doesn't plan to sunset Medicare CQMs until the industry is ready for full implementation of FHIR API technology, which will be no sooner than 5 years from now. So Medicare CQMs are going to be around from 2025 all the way through 2029. The first year that they may sunset them is going to be 2030. So for both MIPS and for APP, ACO's reporting, MIPS is here to stay. These measures are here to stay. They're going to be here at least through 2030. Quality performance standard for shared savings ACOs. So how do you meet the targets that you need for ACO reporting? The first line that you see here meets the alternative quality performance standard and makes you eligible for maximized shared savings. You can see here now it's reporting for ECQMs, MIPS CQMs, or Medicare CQMs. You need to administer the CAHPS for MIPS survey, and they'll have the CMS will calculate the one claim based measure. You also have to report, if you report ECQMs, MIPS CQMs, or Medicare CQMs, and you achieve the health equity adjusted score at or higher than the 40th percentile, you are eligible for maximum savings. You can see a little bit different on the calendar year 2026. It just adds up to the 5 ECQM, MIPS CQMs or Medicare CQMs, and also has now 2 claims-based measures. So that's one way to make yourself available for maximum shared savings. The other way to do that to hit the maximum is to report those same measures that we mentioned above, but you need to have at least one of the 3 outcome measures at the 40th percentile and one of the 4 original measures at the 10th percentile. The remaining, at least one of 3 outcome measures at or higher than 10th, and at least one of the remaining at 40th percentile. Same thing in 2026, however, the numbers move up. So those are the 2 ways that you maximize. You can still participate in shared savings, but at a lower rate, as long as you score at or higher than the 10th percentile on at least one of the 3 outcome measures in 25 and one of 4 in 2026. And if you don't report any of those, you will not be eligible for shared savings and will owe maximum shared losses. Now, I did this again for 2027 and 2028. I'm not going to walk through each one of these, but the biggest difference that we see is that I made a mistake. MIPS CQMs can't be up there up the top. They're no longer going to be available in 2027 and 2028. So you need to report the 8 ECQMs or the Medicare CQMs for 2028. So the only big difference that I was saying is for the calendar year 2028 is the same thing I said earlier for about ECQMs 487 and 493. If they're not available, they're not going to be able to report on those. The last thing in the MSSP world is a complex organizational adjustment. So this is going to be available not only to ACOs, but also available to virtual groups and other APM entities. If you are reporting ECQMs only, so the electronic clinical quality measures, ACOs will receive one measure achievement point for each submitted ECQM. You must meet the case minimums and the data completeness. Each measure can't exceed the maximum 10 measure points, and then the adjustment can't exceed 10% of the total points. So they're giving you the opportunity to have basically, it's very similar to the small practice bonus back in the day, where they would give you an extra, or end-to-end reporting bonus back in the day, where they would give you an extra point for reporting these ECQMs. So they're bringing that back for just these groups. So how do we set ourselves up for success this year? CMS is listening to clinicians. I think that's really, really important. A lot of the changes that they're doing have a lot of comments from people and organizations just like you on this call that are telling them their fears and their doubts of where the program's going, and they're making those changes more than I've seen before. We know MIPS isn't going anywhere anytime soon. Those of us in my world, well, I have job stability for a while. There are more cost measures and MVPs this year as they are pushing to be completely towards MVPs by 2030. And then the program has more complexity, but CMF hopefully is reducing burden on these providers. One thing that they mentioned multiple times during the final rule was how even though more measures are needed for some of these programs, they say it's reducing the burden for two reasons. One, the measures are all built in as common core measures across multiple different reporting types, as well as if you do poorly in one measure and there's only 3 you need to report, the impact is huge. If it's spread out, the impact would be much lower. Little plug for who we are. MIPS Pro, MIPS Cost Analytics help you select measures, report, and see more into your score. We have everybody is based right here, as Lauren said, in 80 degrees, Malvern, Pennsylvania, on November 7th, which is crazy. And we're here to help you reporting, tracking, improving it so that you could really concentrate on what you do best, providing the highest quality of healthcare to your patients. A couple of screens from what it looks like to work with us. Here we have our MIPS Pro dashboard. You can see here the ability for you to track your measures, take a look at it, dig into the columns, and so forth. Here's an example of our cost dashboard. Lauren, you want to kind of give a heads up what this is?
So what we do is we are what's called a qualified entity, and we can get all of the claims data from CMS for any patient that you've seen. So what we do is we get a list of patients from them, and then for each one of those patients, we get all the claims across all providers. And then we use that to actually calculate these measures the same way CMS does, and then provide a dashboard. And not only do we provide a dashboard of the measures and the scores, but allow you to drill into why the scores are the way they are.
Great, thank you very much, Lauren. Here's an example of the ACO reporting that is available in our system, showing not only the reporting rates and the instances, but where you stand compared to the benchmarks that are out there. And that is it. Lauren, do you have any questions that we want to go over? We have a couple minutes.
Here's one. Can ACO submit ECQMs and Medicare CQMs to get the higher of the 2 scores?
So yes, currently the way it is set up is that you can do that. However, there are some tricks to the trade with ECQMs and getting bonus points. with that complex organizational point that's added. So there may be a benefit for that. But yes, you can report both, and CMS will give you the highest of those two scores.
So for 2025, you mentioned that now ACOs are going to have to report the breast cancer screening.
Mm-hmm.
How do they do that?
Breast cancer screening, you could report it in 3 different options. There's the ECQM, as well as there is a registry reporting like us, or you can report it through the Medicare CQMs. All of that can be done at our wonderful registry here at HealthMonix, so that you can maximize your score, track all year, and look at it. But that measure has gone through some changes in the system. So if you're looking at it in your EHR, for instance, there may be differences between the measure that used to be live in your EHR in the past and where it's going now, around age range and so forth, and as well as some of the complexity of the measure.
Can they report it through claims?
You cannot report anything through claims as an ACO. There are only 3 current options, and that's ECQMs, CQMs, and Medicare CQMs. Claims are not available for ACOs. They are not available for practices 16 providers or more, and they are only available for small practices and highly topped out measures almost across the entire board for those. Very hard to score well in those measures, and there's no way of fixing your mistakes.
That's true. And there's no way to know how you're doing.
Right. You won't find out until final scores are available in, the summer of the following year. So we say this, but I tend to not think a lot of people are doing claims-based reporting anymore because of when they took out and they jumped from $30,000 up to $90,000 for the minimum to get into that measure. I think that eliminated a lot of the, claims-based paper clients from having to do this.
So when you talk about data completeness, and you talk about for APP Plus, or I guess for MIPS, or for anything, is it 75% per measure for the data completeness, or is it 75% overall?
Gotcha. Great question. And something that gets asked an awful lot. So the way data completeness works is that is per measure. So if you have 2 measures that are, take breast cancer screening and colorectal screening, have completely different denominators, right? So if you're taking a look at both of those measures, maybe you have 5,000 in one and 4,000 in the other. 75% needs to be met of those eligible instances. So that threshold will have a different number reported. That isn't met, not met, right? Those all are considered complete. It's ones that you don't have an answer for. You don't have it. So, it doesn't say, yes, we did the screening, or no, we didn't do the screening. It says, we don't have the information saying that we did or did not do the screening. That's what incomplete is. It's missing something from it. So CMS wants you to report on 100% of everything. However, they give you that leeway of 75% to deal with issues in your EHR, issues with certain specialties, having multiple EHRs, or not having access to certain patient information if you're working out with a hospital or something like that. So they give you that. But in the end, you need to be 75% of the eligible instances for each measure.
Okay, I'm going to switch gears on you. MVPs.
Mm-hmm.
So somebody noticed that the POC pain measure 144, which I'm sure you're very acquainted with,
mm-hmm.
is listed as removed for traditional MIPS, but it's still in the MVP for advancing cancer care. Can you talk about, because I know that's been the situation for like 110 and 111 last year, and talk about how that works.
So I will caveat and say that I want to verify that and make sure that that's in there for the year. I believe so, but I want to make sure that it's there. But there have been a number of measures that are no longer available in traditional MIPS that they stayed available in in these MVPs. I think very familiar measures like pneumonia and flu vaccine have been a part of MVPs. Colorectal cancer as well as breast cancer screening have been part of MVPs in the past. Basically, they're not available to do in traditional MIPS. They're put into the MVPs because they're part of that full package that CMS wants you to see. When you're doing one of these MVPs, they want that as part of the standard of care, and that's where they want to make sure that the MVPs have those available. But I'll be honest with you, those that they have removed from traditional MIPS but kept them for the MVPs, they're very highly topped out measures that's why they got eliminated from traditional MIPS. And added to the MVPs, they make them very difficult to be reporting on.
Okay, thank you. Yeah, I've noticed that with quite a few measures, they stay in the MVP, but we remove them from traditional MIPS. And then probably, well, 110 and 111 those are odd measures. Aren't they coming back in some form?
Yes, another great question.
Sorry, that's my
No, it's
question.
okay. They're actually coming back, I believe, in two different measures. They are available now in the adult immunization measure, and they're available in there's one other measure, the name skipped my mind. It's up in the 400 areas.
497.
497, our favorite here.
Yeah.
Both of those are now available as part of them. So these are called measures with strata. And I'm not going to dig in 1.5 minutes here to talk to you about strata and measures. I will tell you that we did an excellent webinar with our measures team here at HealthMonix just a couple of weeks ago that explains all the new hard measures that were in 2024, what the different strata mean, and how you can be successful with those measures.
Yeah, that's a great webinar, and if anybody wants to find it, they can find it on our YouTube channel or?
You can go to my YouTube channel. As my kids say, I'm YouTube famous now, but you can go to healthmonix.com. In the top right-hand corner, you're going to see the ability to take a look at what we offer, and webinars are right there for you to click on. You can download and watch any of the webinars at any time.
So it's 3:00. There's still a whole bunch of questions in here, but I think I'll reserve those for you to follow up on individually.
Great. And then before everybody leaves and before the person who put this webinar together, I want to put out, I believe I have it here, a survey real quick. So let me see if I can find it and add it to, they don't make it as easy as they did before. Hold on. There you go. I just want to ask you guys, how prepared, especially after listening to this call, are you for 2025? All right, another 5 seconds, and then I'm going to let everybody rock and roll. If you have any questions, please, my information is right on there. Reach out to me, and we'll be happy to help you. You can see where everybody is, and have a wonderful day.
Thanks, Mike.
Thank you, Lauren, for joining. Appreciate it.